Really excited about our newest white paper at Somnia Anesthesia. I think it's really fascinating. We put forth a lot of educational materials and a lot of sort of thought leadership products, and I think one of the areas that is so misunderstood in anesthesia is the utilization of nurse anesthetists and what a nurse anesthetist is. I never thought it was such a controversial topic until I've been out into the community and had conversations with executives and people in the community and learned that there's really just a lot of different information out there. So my hope is that this is going to give people an opportunity to really read something, listen to what I have to say as well, but look at the white paper and understand a little bit more about what nurse anesthetists do for the delivery of healthcare in this country. It's kind of an interesting and rich history with nurse anesthetists. They've been actually providing anesthesia services from as early as the 1800s. Prior to World War II, the ratio of CRNAs to doctors giving anesthesia was 17-1 in favor of the nurses. So you had 17 times the number of nurse anesthetists giving anesthesia, and then it was after World War II that doctors started to practice medicine in the form of the delivery of anesthesia. Currently there's 44,000 CRNAs delivering care in this country. So what we like about the opportunity is we're in an environment now where there's a demand for higher levels of services juxtaposed against a shortage. We don't have enough anesthesiologists in the country or CRNAs to provide the number of anesthetics that are necessary, but combined, those two groups of people can really do a nice job providing care and a safe job providing care, which is really important. The team care model varies across the different parts of our country, and that's because the Center for Medicare Services has deemed 16 states opt-out states. In fact, it's actually the states themselves that make that decision. And what that means is that in 16 states across the country, CRNAs can practice independently. In the rest of the states, the CRNAs need to practice at a minimum under supervision. And up on labor and delivery, in all 50 states, CRNAs can practice independently. So there's a lot of opportunity to sort of get quality and quantity matched up so that we can provide the highest level of care and service around the country, and that can vary from place to place. Education and licensing and experiencing of nurse anesthetists, experiences of nurse anesthetists is something that would be important for people to understand. Nurse anesthetists are required prior to going to school to have some experience typically in the critical care environment. So they're RNs first. They take that RN degree and they go work in a critical care setting, and then finally they go and get typically a master's degree before becoming nurse anesthetists. Their master's degree program can be 3 years in duration and can include didactic learning as well as clinical on the job, sort of the equivalent of a residency program, taking care of patients. Nurse anesthetists have a society that's been in existence since the 1930s. It began as the NANA and is now as the AANA, and this organization is participated in with almost 97% of the nurse anesthetists in the country. So they're a very strong support system, source of education for nurse anesthetists as well as support for evidence-based practice and quality of care. So what does it all mean? How do we pull it all together? Well, I think the equivalent example is a care team model really gives you the opportunity to have more than one person watching over the care that you're receiving in a hospital setting or in an outpatient setting. You've got the opportunity for people to collaborate. A nurse and a doctor can collaborate on a care plan. A CRNA can function as a physician extender, much like physician assistants do and nurse practitioners do in the operating rooms, in cardiology suites, in gastroenterology suites around the country. This is not a new concept. And in anesthesia, what's nice about it is you've got two people collaborating, two people interfacing with the patient, coming up with a plan, and then you've got the opportunity for specific care to be undertaken by an individual that has a backup, somebody who can be there to support them in a situation that needs an extra set of hands. For hospitals, I think the benefit is we're looking to augment services. All hospitals rely on their operating room as a source of revenue, and they want to expand services. And when you're limited to a single team model as opposed to a care team model, you're not as likely to be able to provide expanded services. And that may mean things that are being done outside of the operating room. There's a big demand for that in hospitals now. Can we provide anesthesia services in the cardiology suites, in the neurology suites, in the gastroenterology suites, in pain management procedure rooms, as well as the main operating rooms themselves? when they're looking to expand services in a horizontal fashion, are there a number of people that can do that in a cost-effective manner? Hospitals are being held accountable through the accountable care organizations and through value-based purchasing. So Medicare is going to be looking at the quality outcomes and is going to look at the results of any care team model or individual model to make sure that quality is being upheld, and there'll be dollars associated with that. So the hospitals have a lot at stake if the model wasn't to make sense, and it makes a lot of sense in so many ways. So in summary, I guess that's kind of a snippet, a little bit, maybe just a teaser or a taste about what the white paper is going to talk about. I think I really would encourage people to look at it. It talks all sorts of specifics as it relates to the history of CRNAs, as well as the utilization of CRNAs, the care team model, not the elimination of physicians, but the addition of CRNAs into the model of caring for patients. It looks at outcome studies and data that's become controversial in the community, but really is really well published and worth looking at. And I hope that you'll take the opportunity to look at it, because it's an important topic and an important piece of the delivery of anesthesia care right now.